This is another thing which you are asked about this table, anticoagulant drugs. To understand this anticoagulant, anticoagulant means preventing the coagulation, either parenteral, IV or oral. So to understand this coagulation, so normal blood is flowing, and whenever there is injury, that is getting clot formation. Injury, clot formation by two ways: extrinsic, intrinsic. So clot is formed. This clot is plugged somewhere where there is injury, and it is preventing bleeding. That is the protective mechanism. But suppose clots are formed not for preventing, automatically clots are formed inside the body. To prevent these clot forms, there are some drugs which will prevent formation of the clot. They are called as clot means coagulation, anticoagulants. If you are giving IV, they are IV anticoagulant. If these are oral. So where these drugs will act, either they have to act on intrinsic or extrinsic mechanism in clot formation, or they should help to dissolve the clots. So to understand this anticoagulant drug, this thing you have to understand first: coagulation. This is clot formation. Coagulation is clot formation, and anticoagulation is opposite, either dissolution of clot or prevention of the clot. So how the clot formed in the body? There are two pathways: intrinsic, extrinsic. Intrinsic means inside the body itself. Extrinsic, whenever there is injury and it is exposed to the outer surface. Intrinsic starts with factor 12, 12 is converted to 11, 11 is converted to 9, 9 converted to 8, and common final pathway is 10. You see, X is the 10. It is the junction of two pathways. And extrinsic, this injury is there and tissue is exposed, so that is tissue factor. This is internal factor. It starts inside the vessel, endothelial, subendothelial inside, and the blood is coming in contact with the traumatic tissue. So tissue factor is initiating, and here is endothelial cells are start. Through the common pathway, prothrombin is a factor 2 which is converted to thrombin. Thrombin acts on fibrinogen 1 and 2 fibrin plots. This is the main end product. This is plugging the injured site and preventing the. Then afterward, fibrin is destroyed, lysed. So that is called as fibrinolytic. Fibrin is destroyed. Lysis of the thrombus formation, that is plasminogen when activated by tissue plasminogen to plasmin. Here is the action of plasmin. Plasmin. So plasminogen, it is converted from plasminogen to plasmin, and this plasmin causes fibrinolysin. Plasmin or fibrinolysin breaks that fibrin clot which dissolves the. So this is the question coming. Fibrinolysis starts by the plasmin, which is converted from plasminogen. This is breakdown. Here we are giving, to prevent this, you give tranexamic acid. Tranexamic acid. This is a drug which is breaking the clot. If you have plugged it and you don't want this plug to be removed, naturally this plug is going to remove by the body through plasmin. So if you give tranexamic acid, most of the time we are doing surgeries, that time if you want to remain that clot for longer time, you give tranexamic acid, ethamsalate, like that. So It prevents plasminogen to convert into plasmin, then plasmin cannot act on the clot, so clot remains for a longer time. This is one way of preventing anticoagulation opposite. Second is protein C and protein S prevents thrombus formation. Here is the prothrombin to thrombin. So C and S formed in the liver as vitamin K dependents. So these are dependent on vitamin K. Endothelial secretes a thrombomolecule which binds to thrombin to form thrombin complexes, and thrombin complexes activate factor C. Factor C is present. Presence of S inactivates 5, 8 and stimulate plasmin formation. So again it is CNS is causing formation of plasmin and destroying this. So protein C, you can see activated C, protein S, inactivation of factor. So it is again acting on the plasmin. The third thing, the question where we are get confused, prevents thrombus formation. Antithrombin 3, this is antithrombin, this is the question. Where does heparin is acting? It is mixing with the antithrombin 3 to form heparin complex. This complex inhibits factor 2, 9, 10, 11, 12. So you can see factor 2 is prothrombin, factor 9 is here, 10, factor 9, this is 10, this is 11, this is 12. All this intrinsic pathway 1, 2, 3, 4. 4 is a common, this is common. So heparin when given, it acts against all these factors to form blood clot. So that is called as antithrombin, through antithrombin. Wherever thrombin is there, antithrombin, you get understood. Do you understand this is formation of thrombin? Against this thrombin, heparin is acting. So what is the mechanism to test C control? Heparin is given, it is acting on 2, 9, 10, 11, 12 through antithrombin. Antithrombin prevents this. Now how to test, control, how much dose has to be given? Here you can see this is intrinsic pathway, longer pathway APTT. This is the test APTT, and for this vitamin K dependent factors are 10, 9, 7, 2. Here is warfarin, and what you are testing here, international ratio INR and his fibrinolysin. So this table now it clears. Low molecular weight heparin decreases factor 10, that is the common pathway. Actually it doesn't require any follow-up. Low molecular heparin, even if it's required, bleeding test, clotting test, not. Unfractioned heparin, it is got fast action, it is forming complex with antithrombin 2, 9, 10, 11. So target of APTT should be 2 to 3. Warfarin, you go oral, vitamin K dependent, it acting on 10, 9, 7, 2 factors. Here you measure INR 2 to 3 times. Here 2 to 3 times APTT. So if you give parenteral anticoagulation for longer time, it may cause bleeding, heparin-induced thrombocytopenia, hyperkalemia. This is the question for heparin. What is the antidote? Protamine sulfate. If you are given large dose of unfractioned heparin, you have to reverse the action. Protamine is to be given. Unfractioned should be stopped 4 to 6 hours before. Low molecular heparin should be stopped 24 hours before, because it has got action. Now here if see a person is given vitamin K, person is getting warfarin, it may create toxicity and major bleeding. Stop warfarin, give prothrombin complexes and vitamin K IV, it will reverse. No bleeding but INR is increased, stop warfarin and give only oral vitamin K. If there is toxicity, patient is bleeding a lot, so you got to give human prothrombin complex. It reverses immediately within an hour. Rapid action, so it has short life, so along with this you have to give vitamin K. If you want to take patient for emergency surgery within 4 to 24, it should be stopped. IV takes 4 hours to work, oral takes 24 hours to work, fresh physician can be used. Preparation of surgery, this is the question. If you want to take patient for elective surgery, stop 2 to 5 days before, and you can start with low molecular heparin, and low molecular weight heparin can be stopped then 24 hours before.